The Pain Train.
Welcome to the first episode of Pain Train. That's pain medicine for trainees. We are your hosts. I'm Bridger Bach.
And Bharat Sharma. The goal of this vodcast series is to serve as an introduction to the world of pain medicine and is targeted to trainees at all levels. We'll be going through the ABA pain medicine keyword list and highlighting parts of it as well.
We'll also cover a few notable academic papers. If you have any questions, feel free to email us at paintrain@gmail.com. We'll get back to you.
All right, fellow trainees, without further ado, let's jump into the first keyword, peripheral mechanisms of nociception. Now, as a warning, some of this material can be more dry than a saltine cracker, but I would argue it's important for a few specific reasons. First, the specialty of pain medicine is based on treating pain states that may in part arise from some of these mechanisms. Second, mutations along the peripheral nociception pathway can predispose certain people to different types of pain. Third, we augment these processes all the time with medications, interventions, therapies, and it's important to understand what you're doing to someone's underlying physiology to decrease the amount of pain they might be experiencing.
So here's the outline for this video. We're going to take a look at the nociceptors, what types of receptors are involved in transduction, what happens when you have tissue damage, and then what synapses are made between the peripheral nervous system and the central nervous system. So, let's dive in. Here we've got a nociceptor. It's a pseudo-unipolar cell. It's got a cell body, you've got a peripheral axon right there, which terminates in some of the peripheral tissues, and you got a central axon, which travels towards the CNS. These cells have free nerve endings that end and reside in some of the tissues throughout the bodies, and these free nerve endings can innervate areas from a couple millimeters, even up to a couple centimeters, so it can be a pretty large receptive field. The cell bodies of nociceptors are housed in a couple different places. So you got the trigeminal ganglion or the Gasserian ganglion, the nose-dose ganglion, and the dorsal root ganglions. I'm sure everyone remembers from basic physiology classes that there are two types of nociceptors. So you got your A-delta fibers and the C fibers. The A-delta fibers are your myelinated fibers. They allow for saltatory conduction. So they're the ones that are associated with that fast, sharp type of pain, just because they're able to conduct a little bit faster. Your C fibers are your unmyelinated fibers. They don't have that saltatory conduction, and they cause that slow burning type of pain. Your alpha delta fibers transmit information around 20 meters per second. So that's essentially the speed of a car. Whereas your C fibers are much slower in comparison. They transmit about 2 meters per second, which is essentially someone walking quickly. So it's human nature to try and categorize everything. And nerves can be categorized anatomically, biochemically, functionally, etc. One way they're grouped is based on the thresholds and responses they have to various types of energy, like heat or mechanical pressure. And here we have a table, and at the top of the table, you're going to see different types of A-delta fibers, or different categorizations. And the way these are categorized are based on their response to heat and mechanical stimuli. So you have AMH1 fibers, you have AMH2 fibers, and AM. So the letters after A basically demonstrate what kind of stimuli they're sensitive to. So M is mechanical, H is heat. The AMH1 fiber is a fiber that's sensitive to both heat and mechanical energy, but it's more sensitive to mechanical stimuli than it is to heat. However, after prolonged exposure to heat, it's going to start to demonstrate an increasing response. AMH2 fibers are also sensitive to both heat and mechanical stimuli, but more sensitive to heat than they are to mechanical stimuli. AM fibers, by definition, have no significant heat response, thus just the A and the M, but they are sensitive to mechanical pressure. In the second table, you got C fibers. There's a couple different types displayed here. So you have the polymodal fibers, which are some of the most common types found throughout the body. You have mechanosensitive, heat-sensitive, or the last type, which is CMIHI, or mechano-insensitive, heat-insensitive. So again, the polymodal fiber is the most common type of nociceptor, and the thresholds are displayed below. But one of the important things to understand is that these thresholds can change in the setting of inflammation. So, and that's true for both A delta fibers and C fibers. So these insensitive neurons can in fact become sensitized to stimuli that weren't initially within their threshold range. So, I want you to take a moment and ask yourself, how does our body turn energy from the physical world into some sort of signal your body can understand? How exactly does that process happen? I mean, we all know that pain is a reality in our lives, but it's tough to fathom exactly how our body's able to understand certain types of energy can be harmful to us. The way our body does it is we have specific channels that allow for the transduction of pain. Now, keyword alert, make a mental note of that, because it's one of the main words you're going to hear when people talk about the process of the body sensing pain. And transduction is basically just a way of converting one energy to another. So here we have heat, mechanical, and chemical energy, and they're being turned into an electrical signal. There are 3 different types of energy that I'm going to cover here as far as receptors our body has to sense these, and that's thermal, chemical, and mechanical receptors. And research is still ongoing in this area, so it's not going to be a comprehensive list, but it's going to highlight a few of the notable receptors. So, tissue damage can begin around 42 degrees Celsius, and our body needs to be able to detect temperatures around this range that could be potentially damaging to our tissues. It does that through TRPV1, TRPV4 receptors. On the other extreme, you need to be able to sense excessive cold temperatures, and we're able to do that through TRPM8 receptors and TRPA1 receptors. And I've listed the receptors out here and then some molecules that can be agonists for those receptors. Also, in tissue damage, you're going to release a variety of chemicals, and your body needs to be able to sense those chemicals. And you're able to do that through, again, the TRPV1 receptor, the acid-sensing ion channel. You have your TRPA1 receptors, and some purine receptors and P2X3 receptors. And for mechanical nociception, this is really an area of active study, but some of the receptors thought to participate are listed out here, but there's a lot of ongoing research still in this area. So, let's hypothesize I'm outside building the shed, and I'm being a little bit careless, and I managed to drive a nail straight through my hand. I'm sitting there, I'm swearing a little bit, but then I pull out my magical microscope and I look to see why the heck is this hurting so bad. And what we see are a few structures in this area. So we blow it up. We got a blood vessel, it's the red straw-like thing. We got a native skin cell kind of down in this bottom left corner represented in brown. Mast cell above it. And then, although it's a little early in the inflammatory process, let's pretend that a neutrophil and a macrophage make an appearance here in the top right corner of the screen. We rupture the cells in the area, and it releases their intracellular contents. So out comes some hydrogen ions, some purine, some ATP, some glutamate. Just a bunch of stuff that was being housed in that cell. Pop, coming out. And then the mast cell starts to produce some prostaglandins. It releases histamine and bradykinin. And then the white blood cells start to release TNF-alpha, a nerve growth factor, bradykinins, interleukins. Now, all these are acting on the respective receptors, and they're causing depolarization of this nociceptor. Notice that some of the molecules are triggering intracellular changes. Bradykinin and prostaglandins in particular can activate G protein signaling cascades. This leads to phosphorylation of channels such as TRPV1, sodium channels, and ultimately nociceptor sensitization. That's why pain can get worse in the setting of inflammation. And not only that, but nerve growth factor, TNF-alpha, interleukins can lead to activation of intracellular signaling cascades like MAPK and ultimately cause DNA acetylation, transcription, and this can cause upregulation of channel production and, furthering the pain state that the patient might feel. An important takeaway from this slide is that inflammation can sensitize neurons, and that due to the number of molecules and receptors in this process, we don't have a magic bullet to target pain. We can decrease pain by targeting some of the components of the inflammatory cascade through medications like NSAIDs, anti-NGF, TNF-alpha agents, but we just aren't able to block the whole slew of receptors and signaling molecules involved. It's just too much. The nociceptor also plays a role in the inflammatory process, so you'll see substance P right here. That's a peptide that's secreted by the nociceptor, and it causes vasodilation, increases vascular permeability, and you get a further influx of inflammatory cells, so it can perpetuate this inflammatory process. As I mentioned before, some mutations can lead to differences in the way individuals experience pain. I want to give you some examples here. So, a gain-of-function mutation of the SCN9A gene, which encodes for the sodium voltage-gated channel Na1.7, is responsible for the intermittent burning pain of primary erythromelalgia. However, a loss of function of the same gene can lead to congenital insensitivity to pain. To kind of tie that into the beginning again, people are going to experience pain in different ways based on what their genetic makeup is, what their body's been exposed to throughout their life. And it's just important to keep that in mind when you're treating patients and seeing patients in clinic. All right, let's go over a question real quick. We have a 48-year-old female with a pretty nasty compound tib-fib fracture. What changes are occurring in the setting of this tissue damage and inflammation that could make the area more tender in the future? So we have A, unmasking of silent or CMIHI nociceptors. B, phosphorylation of TRPV1 in sodium channel receptors. C, increased mRNA transcription encoding different channels. D, activation of the MAPK pathway. Or E, all of the above. And the answer, of course, is all of the above. In the setting of inflammation, you have unmasking of the silent nociceptors. You're phosphorylating those channels, the TRPV1, the sodium channels. There's activation of intracellular signaling cascades. You have activation of the MAPK pathway. You have increased DNA transcription. You have DNA acetylation. So all of this is going to lead to a pretty painful injury. Nociceptors synapse in the dorsal horn of the spinal cord. And although there can be a lot of variability in synaptic connections, some patterns do exist. I'm going to go over a lot of those patterns in the next episode, which is going to be central mechanisms of pain. But briefly, peptidergic neurons, which are C and alpha delta fibers that contain peptides like substance P, or calcitonin gene-related peptides, they terminate in lamina 1 primarily. They do have some projections to deeper Rex lamina. And then you have non-peptidergic C nociceptors, which express MASG-related protein, and they stain for IB4. And these project to like a central portion of lamina 2. And then you have some visceral C nociceptors, some alpha-delta fibers, some somatic C fibers that again project to deeper Rex lamina, where they synapse with wide dynamic range neurons, not nociceptor-specific neurons. And again, we'll cover this in the next keyword. Stay tuned. Central mechanisms of nociception.